नमस्कार। टेलीकॉन्फ्रेंस की एक और कड़ी लेकर मैं आपके समक्ष उपस्थित हूँ। अभी तक हमने सभी विकलांगताओं के आइडेंटिफिकेशन, इंटरवेंशन, रेफरल, रिहैबिलिटेशन, वोकेशनल एंड एजुकेशनल एस्पेक्ट्स के बारे में बात की। हमारे बहुत सारे विशेषज्ञों ने हमें बताया कि इन डिसेबिलिटीज़ के डिफरेंट एस्पेक्ट्स क्या हैं और कैसे हम इस तरह के लोगों के साथ काम कर सकते हैं। आज हम अपने विशेषज्ञों से जानेंगे कि चाइल्डहुड मेंटल इलनेस क्या है और इसकी पहचान कैसे की जा सकती है, कौन कौन से सिम्टम्स हैं और क्या इंटरवेंशन हो सकता है। साधारणतः लोग मानसिक मंदता और मेंटल इलनेस यानी मानसिक रोग को इंटरचेंजेबली यूज़ करते हैं। वो मेंटल इलनेस और मेंटल रिटार्डेशन में कोई फ़र्क नहीं समझते। इसकी वजह से बहुत सी भ्रांतियां भी पैदा होती हैं, जबकि ऐसा नहीं है। मेंटल इलनेस एक रोग है, जबकि मेंटल रिटार्डेशन एक कंडीशन है। यदि समय रहते पता चल जाए कि मेंटल इलनेस है और उसके कारणों का पता लगाकर सही इंटरवेंशन किया जाए, इलाज किया जाए, इसके अलावा काउंसलिंग और एक मल्टी डिसिप्लिनरी टीम के सहयोग से हम समय पर इंटरवेंशन करके बच्चों की इस कमी को दूर कर सकते हैं। अभी तक आप लोगों के सहयोग से हम लोग 31 टेलीकॉन्फ्रेंस कार्यक्रम कर चुके हैं, जिसमें हमने बहुत सारे विषयों के ऊपर बात की। जैसा कि दर्शकों का सुझाव था कि टेलीकॉन्फ्रेंस का समय 2:30 बजे से 3:30 बजे तक रखना चाहिए, तो आपके सुझाव को मानकर अगले महीने से जब हम सेकेंड फेज़ का प्रोग्राम शुरू करेंगे, उसमें हमारा टेलीकॉन्फ्रेंस का समय 2:30 बजे से 3:30 बजे तक रहेगा। पहली टेलीकॉन्फ्रेंस जो सेकेंड फेज़ में होगी वो RCI और RCI एक्ट इसके इम्प्लीमेंटेशन के विषय में होगी। इस टेलीकॉन्फ्रेंस को RCI के चेयरमैन और मेंबर सेक्रेटरी संबोधित करेंगे 23 नवंबर को 2:30 बजे से 3:30 बजे तक। कार्यक्रम को आगे बढ़ाने से पहले मैं दर्शकों से अनुरोध करूंगी कि हमारे फ़ोन नंबर नोट कर लें। टोल फ्री नंबर है 1600112345। टोल फ्री नंबर एक बार फिर दोहरा देती हूँ, 1600112345। STD नंबर है 01129532845। दूसरा नंबर है 29532844। एक और नंबर है 29536131। आप फैक्स के द्वारा भी अपने सवाल पूछ सकते हैं। फैक्स नंबर है 01129536134। आज स्टूडियो में हमारे साथ मौजूद हैं ऑल इंडिया इंस्टीट्यूट ऑफ मेडिकल साइंसेज के 2 विशेषज्ञ। मेरे साथ हैं डॉक्टर मंजू मेहता, आप एम्स में क्लिनिकल साइकोलॉजी डिपार्टमेंट में हेड हैं। प्रोफेसर मंजू मेहता ने UK से मेडिकल एजुकेशनल टेक्नोलॉजी की ट्रेनिंग ली है। आप पिछले 29 वर्षों से इस क्षेत्र में बहुत महत्वपूर्ण योगदान कर रही हैं। क्लिनिकल साइकोलॉजी के क्षेत्र में आपके योगदान के लिए निमहांस की तरफ से आपको गोविंद स्वामी मेमोरियल गोल्ड मेडल मिल चुका है और CS कैंग ओरेशन अवार्ड भी आपको वर्ष 2004 में मिल चुका है। डॉक्टर मंजू मेहता, आपका हमारे स्टूडियो में स्वागत है। हमारे दूसरे विशेषज्ञ डॉक्टर राजेश सागर हैं। आप एम्स में साइकेट्रिक डिपार्टमेंट में एसोसिएट प्रोफेसर हैं। आपने 75 से ज़्यादा रिसर्च पेपर पब्लिश किए हैं। इसके अलावा बहुत सारे रिसर्च स्टडीज़ में आप लोगों को गाइड कर रहे हैं और आप 1997 से एम्स में एसोसिएट प्रोफेसर के तौर पर कार्यरत हैं। डॉक्टर सागर, हमारे स्टूडियो में आपका स्वागत है। कार्यक्रम को आगे बढ़ाने से पहले मैं डॉक्टर सागर से अनुरोध करती हूँ कि वो हमें बताएं कि चाइल्ड मेंटल इलनेस क्या है। हम जब चाइल्ड मेंटल इलनेस की बात करते हैं तो क्या हमारे दिमाग में आता है और किस को हम चाइल्ड मेंटल इलनेस कह सकते हैं? डॉक्टर सागर।
डॉक्टर हेमलता, ऐसा है कि हमें ये मानना चाहिए कि जो बच्चों जो जो 15 साल से जो कम उम्र के जो हमारे देश में लोग हैं, वो उनकी आबादी बहुत ज़्यादा है। ये कहा जाता है कि जो हमारा देश है वो यंग लोगों का देश है, और 40% आबादी है 15 साल से कम उम्र की। और तो आप ये जान सकते हैं कि जो 40% की जो आबादी है, उसकी जो उसकी हेल्थ और मेंटल हेल्थ बहुत बहुत महत्वपूर्ण है। और अभी तक ये देखा गया है कि जो मेंटल इलनेस के ऊपर इतना ध्यान नहीं गया, लेकिन अब ये माना जा चुका है कि कुछ, और एक तो आबादी इतनी ज़्यादा है इस वर्ग के अंदर, और दूसरा कुछ बीमारियों को हम प्रिवेंट कर सकते हैं, क्योंकि खासकर ये जो बच्चों में जो प्रॉब्लम्स होती हैं, ये अडल्टहुड तक भी चलती रहती हैं। तो ये बहुत ज़रूरी है कि उस उम्र में जितने जल्दी हम उस बीमारी को पहचानें, और जिससे कि आगे आने आने वाले जो 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 प्रॉब्लम्स हैं, जो डिसफंक्शन हैं, जो इम्पेयरमेंट्स हैं, उनको हम रोक सकें। और इसीलिए हमारे लिए बहुत ज़रूरी है कि हम सब लोगों को अवगत कराएं कि ये प्रॉब्लम्स क्या हैं, कैसे उसको आइडेंटिफाई करना है, और कैसे उनको पकड़ना है जितनी जल्दी हो सके संभव उसी में, जिससे कि आने वाले वक्त में जो बच्चे का जो भविष्य है, जो वो एडल्टहुड में जाएंगे, वो सही रूप से मानसिक तौर पे वो जा सके। और और ये बीमारियां जो हैं, अनेक प्रकार की बीमारियां होती हैं। भ्रम होता है कि बच्चों में तो मानसिक कोई बीमारी होती नहीं है, सिर्फ मेंटल रिटार्डेशन होता है, बट ऐसा नहीं है। क्योंकि आज के युग में इतने फास्ट पेस लाइफ है, इतने स्ट्रेस हैं, इतनी सारी प्रॉब्लम्स हैं, वो भी उसी तरह से प्रॉब्लम्स में उनको हो सकती हैं। और हम देख रहे हैं कि हमारा जो फैमिली स्ट्रक्चर है वो भी टूट रहा है, और हमारा जो हम वेस्टर्नाइजेशन की तरफ जा रहे हैं। तो हमारी जो प्रॉब्लम, जो ये कहा जाता था कि बच्चों की जो प्रॉब्लम है सिर्फ वेस्टर्न वर्ल्ड में है, ऐसा बिल्कुल नहीं है। और आने वाले वक्त के लिए हमें पूरा सचेत होना पड़ेगा कि जो मेंटल इलनेस है, चाइल्डहुड मेंटल इलनेस है, इन पर हम पूरा ध्यान दें और पूरी तरह से हम इसको समझें, और जिससे कि हम उन बच्चों को, और जो एडोलेसेंस में जो जा रहे हैं, एडोलेसेंस का पीरियड बड़ा क्रूशियल फेज होता है, क्योंकि उसमें बच्चा पढ़ाई करता है, और उसको हमें मानना चाहिए कि अगर उसका बेस ही अगर हम ठीक नहीं होगा, तो आगे जाके वो ठीक एक अच्छा नागरिक और एक अच्छा व्यक्ति फैमिली के लिए नहीं, और कम्युनिटी के लिए नहीं बन सकता। तो उस रूप में मैं ये कहना चाहूँगा कि हमारे देश में जो प्रॉब्लम्स हैं, ये देखा गया है कि जो इसमें एक रूप से इसकी जो स्टडी की जाती है कि कितनी मैग्नीट्यूड ऑफ प्रॉब्लम्स हैं, कितनी ज़्यादा ये प्रॉब्लम्स हैं, वो 3 भागों में की जा सकती हैं। एक तो ये है कि जनरल पॉपुलेशन में, एक मतलब एक आम एक पॉपुलेशन में चाइल्डहुड मेंटल डिसऑर्डर कितने हैं। तो मतलब बहुत ज़्यादा वेरिएशन है, मतलब 6.9 से 172.7 पर 1000। तो समझ लीजिए कि लगभग 17% जो है जो बच्चे हैं वो चाइल्डहुड मेंटल डिसऑर्डर से हो सकते हैं। जबकि कुछ स्टडीज़ जो हैं वो काफ़ी जो बहुत वेरिएशन रखती हैं, मगर जनरल पॉपुलेशन 17% भी बहुत ज़्यादा है। विदेशों में ये देखा गया है, वेस्टर्न पॉपुलेशन में 1/5 ऑफ द पॉपुलेशन, मिनिमम 1/5, मतलब 20% से ज़्यादा, 20 से 25% जो बच्चे हैं उनको ये बीमारियां होती हैं, और ये काफ़ी ज़्यादा प्रॉब्लम है। और दूसरी ये देखा गया है कि चूंकि जनरल पॉपुलेशन संभव नहीं है, जो स्टडीज़ जो हैं, तो स्कूल बेस्ड, क्योंकि अक्सर जो बच्चे हैं ऑलमोस्ट 90% स्कूल में जाते हैं, क्योंकि हालांकि हमारे देश में स्कूल ड्रॉप आउट्स भी बहुत हैं। तो कुछ जो स्कूल बेस्ड स्टडी जो हमारे देश में हुई हैं, उसमें भी प्रतिशत, मतलब जैसे साइकोसिस है जो कि बहुत सीवियर बीमारी है, 2% है। न्यूरोटिक जो डिसऑर्डर्स हैं जैसे एंजाइटी, सोमेटोफॉर्म, पेन सिम्टम्स, वो बल्कि 160 पर 1000 है। और तो ये जो प्रॉब्लम है, अगर मान लीजिए 160 पर 1000 मतलब 16%, ये भी काफ़ी ज़्यादा मैग्नीट्यूड है। अगर स्कूल बेस, अगर एक स्कूल में मान लीजिए 1000 बच्चे हैं, तो उसमें 160 बच्चों को न्यूरोटिक प्रॉब्लम्स होंगी। तो ये रिसर्च में देखा गया। और क्लिनिक बेस्ड का मतलब ये है कि जो हॉस्पिटल्स में आते हैं, जैसे हमारी बच्चों की अलग से ओपीडी होती है हमारे डिपार्टमेंट में, हफ्ते में एक बार होती है, तो उसमें प्रतिशत जो है 8.2 से 28% होता है। तो ये भी बहुत ज़्यादा नंबर है, और ये देखा गया है कि पिछले कुछ सालों से ये नंबर बढ़ता जा रहा है, लोगों में अवेयरनेस हो रही है, हमारे लाइफ स्ट्रेस अलग हैं, और ये जो नंबर है, जैसे आज से जो 10 साल पहले था और आज में काफ़ी फ़र्क है, और नंबर ये धीरे धीरे बढ़ता जा रहा है। अगर इसी रेट से बढ़ता गया, आने वाले वक्त में और भी बच्चों को ये प्रॉब्लम होगी, और हमें उन सब के लिए हमें जागरूक होना है।
थैंक यू डॉक्टर सागर। डॉक्टर मेहता, Could you tell us that child mental illness is different from adult mental illness? Is it true?
Yeah, of course, because in children the problems are related to their development. So initially when we see children in the age group say 2 years to 5 6 years, many of the problems are part and parcel of the developmental period, like temper tantrums, having child asking for demandingness and low frustration tolerance. They are all part of his developmental thing. Even speech problems, enuresis, these are also part and parcel of the developmental problems. Then as they grow up, then further lots of academic problems come up which are related to their mental health. Either it is because of anxiety, or it is because of specific learning disability, or because of poor conditioning and poor disciplining at home. Children are not able to give attention and concentration in their task, and sometimes there could be little bit of genetics also involved in that. So lots of environmental, developmental and behavioral problems are part and parcel of childhood, which is different from adults, and their classification is, that is why, absolutely different from that of an adult.
And what are the types of mental illness in children? Can you
See,
tell our
broadly we
viewers?
try to classify these mental disorders. One is according to the developmental delays. In developmental delays, leaving mental retardation aside, there are speech delays, there are also delays in social and emotional growth of the child. And in this, sometimes we also take pervasive developmental disorders, which is autism, Asperger's, those problems are also included. Then there are behavioral problems, and behavioral problems are hyperactivity, conduct disorders, and in this the child may not be able to control, or he has non-compliance at home and at school, so those would be problems. Then there are certain disorders which are related to physical aspects. For example, somatoform disorders, abdominal pain and headache is very common in children, and these are, out of 100 cases, 80 cases are because of psychological factors, abdominal pain and headache. It is not purely organic. Then there are also children who have physical illness, but they have an overlay of psychological and behavioral problems. So that's another group which becomes very important. And lastly, in some cases there is also childhood schizophrenia, depression and other serious form of disorders can be seen.
Thank you, Dr. Mehta. Dr. Sagar, how do we do the assessment of mental illness?
देखिए, the point is that for assessment, as in psychiatry, we should be aware that for psychiatric disorder, the mainstay of assessment is the interview or say history taking. And we should understand in psychiatric disorders, like for other branches of medicine, like we have there's so much reliance is given for investigations, but in psychiatric disorders, the assessment is predominantly a interview or say history taking, and that forms the major form of assessment. Once that is over, then we go into the examination part. Examination part again is a general physical examination and mental status examination. Like in general, again, when we talk about evaluation, there could be clinical evaluation, then there is a diagnostic interview, then there are certain rating scales are also there for children, like for ADHD there are different forms of rating scales are there. Kuhner's rating scale, which again has a parent version, teacher version and so on, and behavioral observation, because as Dr. Mehta was saying that these children have a lot of them have behavioral problems, and to have a proper assessment of behavior, it is very important to have to do a behavioral assessment. Now behavioral analysis is done on ABC sequence, that is antecedent, behavior and consequence, by which we can assess, we can evaluate what the baseline behavior is. Unless we know that what the baseline behavior is, we cannot do the changes, we cannot modify it. So it's very important to have a proper behavioral analysis of that particular behavior. Then there are certain laboratory investigations, like say for example, is there any comorbid medical condition, comorbid medical condition and other types of medical problems are there, like simple like fever, and so baseline investigations are done for hyperactivity. We may do thyroid test, that is also important. Any endocrinal problems or any investigation which is, if there is a brain dysfunction, so we may get imaging studies, or if there is a suggestion of any seizure disorder, then we may do a EEG, so like this. So the assessment basically comprises of three phases. One is the clinical interview or diagnostic interview, then the examination part, which may include the behavioral assessment or behavioral rating scales, then in some cases the investigations are also important.
Doctor, can you tell us about this ADHD?
Yeah, ADHD again, briefly what I can say is attention deficit hyperactivity disorder, and this is how the short form ADHD is, and it's one of the most commonly diagnosed behavioral disorder in the childhood. And now what we have seen is in recent times, a lot of teachers and parents are coming to us with this problem. Earlier they were perhaps getting unnoticed, or they were not so much bothered, but now they are coming more and more because they want to have a treatment. Earlier they never knew that there is a treatment for this disorder. They were not being aware of about this disorder. And children with ADHD have difficulty in the impairment, which I will we should understand that what we are talking of ADHD is young children, adolescent, and we know that this is a very crucial phase of one life. So if any person who has this problem can have a very serious repercussion and serious problems in their functioning, and they may also have experience like long-term adverse effects on academic performance, vocational success, social emotional development, and peer relationship. And ADHD is heterogeneous condition of multiple etiology, so we should know this. Incidence, as I said, is very common, 2 to 20% in all school age population. In India also studies have been done, up to 8.1% of the children have ADHD, and this it is more prevalent in boys, 5:1 is the ratio, and usually the onset is in first 5 years, because symptoms are there in first 5 years, and they are evident in first 5 years of life, but common age of diagnosis is 9 years. The reason is that because before 5 years the parents are not very aware of, because child is never asked to sit quiet, or only when the child goes to school, they are in school, and then when the child is expected to be in a structural environment, then only when the child is not doing that, then they think that okay, this person may have a ADHD. So that's the common age of diagnosis. When the child starts going to school, they are not sitting at one place, they have a hyperactivity problem, then that is the time to make a diagnosis and they come for the treatment. Then siblings also may have increased risk for ADHD, disruptive disorders, anxiety, and so on, academic failures, and parents also may have increased risk for ADHD, sociopathy, alcohol use, so these kind of disorder may be there in parents also. Now there cardinally, when we talk of ADHD, we should understand that there are three basic symptoms. One is what is known as inattention or poor attention, then second is hyperactivity, and third is impulsivity. So these form the basic triad of symptoms in ADHD. Inattention, as the term suggests, it often fails to give close attention to details or makes a careless mistake. That's a very common problem in this, because of a short attention span, and often has a difficulty sustaining attention in task or play activities, because they are not able to complete one task. They will shift on from one task to other. That's a common complaint in the school. That's a class teacher, that they will not be able to complete the classwork. Then often does not seem to listen when spoken to directly. What happens, like, okay, they may be making eye contact, but they will not pay attention to it. They will not be attentive when we are speaking to them. So they don't listen at times, even though it seems that they are looking at you. Often does not follow through on instructions and fails to finish schoolwork, and so on. So these are the problems which are related to poor attention or inattention. Then also there is other list of inattention problems, like often a difficult organizing tasks and activities, often avoids, dislikes, reluctant to engage in tasks, and so on. So whole list of symptoms are there which is related to poor attention. Then hyperactivity. As I was saying, hyperactivity is also one of the key features, and because they are not able to sit at one place, they are very fidgety, they are very restless, and that's the common complaint of class teacher, and also parents also have this complaint, especially when a guest have come, when new person come in the at home, then they are not at one place. Even at dining table, they are not at sitting quietly. So when they are expected to sit quiet, So restlessness, fidgetiness, so that's a, and basic hyperactivity, that increased activity, so that's one of the key feature of ADHD. Then impulsivity, sudden blurts out answer before listening to a question. Suddenly in the classroom they will stand up and talk to teacher, and and difficulty in awaiting their turn when some activity is going on. So they are suddenly impulsive. So these are basic characteristics like poor attention, hyperactivity, impulsivity. Sometimes hyperactivity, impulses combined together, they are related together, and inattention itself is a major problem. So in a child who is school going, inattention becomes a major problem, because that's one of the common complaint कि तो समझ में नहीं आ रहा है इसको, और ये काम पूरा नहीं कर पाता, और so that, and that's a major complaint at times. Whereas parents are more concerned with the hyperactivity problem, because वो एक जगह टिक के नहीं बैठ रहा और कुछ ना कुछ करते रहता है, so that's a major problem with the parents. So in general these are symptoms of attention deficit hyperactivity disorder or ADHD.
डॉक्टर साहब, एक मुझे जो लग रहा है कि जो बच्चे हैं, जो आपने बताया ADHD जिनको है, और कई बार ऐसा होता है कि बच्चे अपनी क्लास में जो काम दिया जा रहा है या घर में जो काम दिया जा रहा है उसमें बहुत अटेंशन नहीं दे पाते हैं, या जैसे होमवर्क बच्चा नहीं करना चाह रहा है या खेलने में उसका बहुत मन है, तो हम कैसे पता करें कि ADHD है या बच्चा सिर्फ लापरवाह हो रहा है?
बिल्कुल सही कहा आपने, क्योंकि कभी कभी जैसे मैंने पहले भी कहा कि इसका जो डायग्नोसिस है, और इसमें अक्सर ये देखा गया है कि इसमें प्रॉब्लम आती है, बिकॉज क्योंकि ये प्रॉब्लम जैसे आपके पास डॉक्टर के पास तब आएंगे जब पेरेंट्स लगेगा ये प्रॉब्लम है, और पेरेंट्स अक्सर ये कहते हैं कि नहीं ये तो बोर्डम है, ये लापरवाह है, ये लैक ऑफ मोटिवेशन है, इसको ये प्रॉब्लम हो ही नहीं सकती है। परंतु ये मानना चाहिए कि देखिए कोई भी अगर प्रॉब्लम होती है, क्योंकि ये हो सकता है कि नॉर्मल वेरिएशन हो, ये क्योंकि हमने देखा है एक नॉर्मल टेम्परामेंट होता है, एक टेम्परामेंट होता है एक्टिविटी लेवल। कुछ बच्चों का हमने देखा एक्टिविटी लेवल बहुत ज़्यादा होता है, कुछ बच्चों का एक्टिविटी लेवल बहुत कम होता है, वो सुस्त रहते हैं, लेथार्जिक रहते हैं, क्योंकि उनका बेसिक टेम्परामेंट ऐसा है। और लेकिन कुछ है जो कि बहुत एक्टिव होते हैं, तो ये बेसिक वेरिएशन ऑफ टेम्परामेंट है पहली बात। लेकिन और ये बात बिल्कुल सही है कि ये अगर टेम्परामेंट है और डिसऑर्डर कब बन गया, और ये इसको कब डिसऑर्डर हो गया जिससे कि इसको ट्रीटमेंट की जरूरत है। हमें ये मानना चाहिए डिसऑर्डर तब होगा जब हमें लगेगा ये जो बच्चा है ये अपने एकेडमिक परफॉर्मेंस में डिक्लाइन हो गया है, जो इसको करना चाहिए वो नहीं कर रहा है, और जो इसको होमवर्क दिया गया है वो नहीं कर रहा है, क्लास वर्क में परेशान कर रहा है और बच्चों को भी तंग कर रहा है, हाइपर एक्टिविटी लेवल से औरों को भी परेशान कर रहा है, क्लास में एक रूल्स एंड रेगुलेशन का एक वो होना चाहिए, डेकोरम होना चाहिए, वो मेंटेन नहीं कर रहा है। और अक्सर टीचर की कंप्लेंट आ रही है कि उसकी डायरी में कि ये औरों को तंग कर रहा है, और पेरेंट टीचर मीटिंग में इस तरह का डिस्कशन हो कि ये औरों को भी तंग करता है क्लास में टिक के। तो जहाँ पे लगे कि वो जो समस्या है बहुत ज़्यादा हो गई है और उससे उसको हानि हो रही है और डिस्फंक्शन हो रहा है उसका। अब डिस्फंक्शन उसके एकेडमिक में हो सकता है, सोशल में हो सकता है, और बच्चे जो हैं और उससे दूर भागते हैं, और बच्चे उससे दोस्ती नहीं करना चाहते हैं, और तो ये सब चीजें अगर जहां पे लगेगा डिस्फंक्शन हो गया तो इसका मतलब है डिसऑर्डर है और उसमें उसकी ट्रीटमेंट की जरूरत है।
Dr. Hemlata, I'd like to add one thing more, that very often parents confuse between overactivity and hyperactivity. Yeah. Overactivity is something when the child is more active but he is not having a disorder. Okay. Temperamentally, what Dr. Sagar was saying is that overactive child can be very productive. He can be very useful if his energy is channelized in the right way. But hyperactivity is where his energy is so much and it is so destructive and disorganized that instead of doing good to him and to other people, it is harmful. So many parents at times, even if the child is overactive, because of over concern, they want to know whether the child is having a problem or he is normal.
तो मतलब आप लोग जो कह रहे हैं उसका मतलब ये है कि जो हाइपर एक्टिविटी और ओवर एक्टिव जो होना है उसके बीच में एक बहुत थिन लाइन है।
या
तो उसको पहचानने के लिए पेरेंट्स को और टीचर्स को किन किन बातों का ध्यान रखना चाहिए? डॉक्टर सागर, आप
देखिए जैसे बताया कि क्योंकि ओवर एक्टिव चाइल्ड भी बहुत प्रोडक्टिव हो सकता है, और बेसिक रूल इसकी अगर हम इसको हम सोचें, क्योंकि पेरेंट्स को समझ में नहीं आएगा हाइपर एक्टिविटी क्या है, ओवर एक्टिविटी क्या है, उनके हिसाब से तो यह है कि बच्चा टिक के नहीं बैठता है और एक जगह काम नहीं कर सकता है, काम को पूरा नहीं कर पाता, बहुत चंचल है, बिकॉज ये अक्सर उनकी कंप्लेन होती है, चंचल है। लेकिन ट्रीटमेंट के लिए कंसल्टेशन जब आनी चाहिए जब जहाँ पे लगने लगे कि इसकी जो क्योंकि उसके अपने कंट्रोल में नहीं है और उससे उसको हानि पहुंच रही है, उसकी हानि अगर पहुंचनी शुरू हो जाए, डिस्फंक्शन शुरू हो जाए, तो वहां पे उसको एक इलाज की जरूरत है, एक कंसल्टेशन की जरूरत है। और हो सकता है दवा भी ना दिए जाए, हो सकता है सिर्फ काउंसलिंग से, बातचीत से ही ठीक हो जाए, क्योंकि हो सकता है कि कभी कभी जो हाइपर एक्टिविटी है कुछ सिचुएशन स्पेसिफिक भी होती है, तो क्योंकि ये जानना बहुत जरूरी है किस सिचुएशन में है, तो जहाँ पे लगे कि उसको डिस्फंक्शन शुरू हो गया है वहां पर उसको ट्रीटमेंट की जरूरत है और एटलीस्ट उसको कंसल्टेशन की जरूरत है।
Thank you, doctor. Can these symptoms be seen with other disorders?
Yes.
Are there chances?
Definitely, because that's what I think it's important to have, what the differential diagnosis is and how this particular disorder can be differentiated from other disorders. One, of course, what I have said is a temperamental variation is there, because it could be the normal range. As we know that, some children are less active, some are more active. So that's one condition. Second is एंजाइटी डिसऑर्डर। अक्सर देखा गया है कि कुछ बच्चे जो हैं बिकॉज एंग्शियस, so they may also be hyperactive. Because of anxiety they may have a poor attention span. क्या होता है कि वो कई पेरेंट का एकदम भूल जाता है, इसको पता नहीं तो कहाँ रखा है। चाइल्ड में बी वेरी एंग्शियस। एंजाइटी का वन ऑफ द की फीचर इज अ पुअर अटेंशन स्पैन। सो अक्सर ये देखा गया है कि इसके अंदर जो है एंजाइटी डिसऑर्डर और ये ADHD के सिम्टम जो है ओवरलैप कर सकते हैं, और एंजाइटी डिसऑर्डर भी हमें मालूम है कि बहुत कॉमन है बच्चों के अंदर। और नंबर 3 जो इंपॉर्टेंट कंडीशन है जैसे मूड डिसऑर्डर मीन्स डिप्रेशन। डिप्रेशन में भी जो खासकर प्री प्यूबर्टल है, मतलब मान लीजिए 12 साल से कम उम्र के जो बच्चे, खासकर जो बॉयज हैं, उनके भी डिप्रेशन का में उदासी नहीं होगी, उनके अंदर बिहेवियरल सिम्टम्स ज़्यादा होते हैं, उनमें एक्टिविटी लेवल भी बड़ा होता है। और जबकि जब बच्चा बड़ा होता है, एडोलेसेंस और एडल्ट में हमें डिप्रेसिव मूड आता है, जब उदास बहुत ही ऑब्वियस सिम्टम लगता है, लेकिन बच्चों में खासकर प्री प्यूबर्टल बिफोर एडोलेसेंस जो चिल्ड्रन में ये चीज़ इंक्रीज एक्टिविटी के रूप में आती है। ये तो ये भी इसको भी डिफरेंशिएट करना बहुत जरूरी है, कहीं बच्चे को डिप्रेशन तो नहीं है। और ये भी माना गया है कि ADHD के बच्चों में जिनको ADHD होता है, डिप्रेशन भी हो सकता है इन एडोलेसेंस और एडल्टहुड। सो ये भी समानता है उसके अंदर। परवेजिव डेवलपमेंटल डिसऑर्डर, ये कंडीशन है जिसमें जानना बहुत जरूरी है, बिकॉज ये हमें डॉक्टर मोहता मैं पहले बताया कि डेवलपमेंटल डिसऑर्डर और परवेजिव डेवलपमेंटल डिसऑर्डर, या जिसको पहले ऑटिज्म कहते थे, जो ऑटिस्टिक बच्चा होता है उसमें भी हाइपर एक्टिव लेवल बहुत ज़्यादा होता है, वो भी एक जगह टिक के नहीं बैठ सकता, उसको स्टीरियोटाइप बिहेवियर होता है, गोल गोल घूमेगा। तो अक्सर कभी कभी क्या होता है, बस पेरेंट्स ये कंप्लेन लेके आते हैं कि ये तो बच्चा हाइपर एक्टिव है, टिक के नहीं बैठता। जब आप डिटेल में असेसमेंट करते हैं तब पता लगता है कि कहीं इसको ऑटिज्म तो नहीं है, परवेजिव डेवलपमेंटल डिसऑर्डर तो नहीं है, क्योंकि ये डेवलपमेंटल डिसऑर्डर है और इसमें भी बुद्धि कम होती है और इसमें स्टीरियोटाइप बिहेवियर होता है और लैक ऑफ कम्युनिकेशन होता है। ये भी मानना चाहिए कि जैसे मान लीजिए कोई बच्चा है जो कम्युनिकेट नहीं कर पा रहा है, जिसको ऑटिज्म है, तो कैसे लोगों का अटेंशन ध्यान लेगा, हाइपर एक्टिव होके, को चंचल होके लोगों का अटेंशन लेने के लिए, क्योंकि वो बोल नहीं पा रहा है। तो ये पूरा असेसमेंट में ये भी ये कंडीशन रूल आउट करना बहुत जरूरी है। स्किज़ोफ्रेनिया अगर बच्चा थोड़ा बड़ा है, एडोलेसेंस में है, तो वो भी ऐसे प्रेजेंट कर सकता है। मेंटल रिटार्डेशन, जिनकी बुद्धि कम होती है, उनको भी खासकर हाइपर एक्टिविटी भी एक खास सिम्टम है होता है उनका, वो भी चंचलता, बिहेवियरल प्रॉब्लम में चंचलता एक बहुत कॉमन सिम्टम है। लर्निंग डिसऑर्डर, और दे कैन बी कोमॉर्बिड लर्निंग डिसऑर्डर लाइक डिसलेक्सिया, specific learning disability, they also can present like this, because if a child is not able to do something, then child will not have attention to sit at one place and they will be hyperactive, and this is what commonly we have seen, they come with a complaint from school teacher because he has a scholastic backwardness or lack of school performance, but ultimately they are found to have a ADHD. कंडक्ट डिसऑर्डर भी एक कंडीशन है जहाँ पे मतलब वो नॉर्म्स को फॉलो नहीं करते, स्टीलिंग, लाइंग, ये सारा बिहेवियर होता है, एंड सब्सटेंस अब्यूज। तो ये जो कंडीशंस हैं ये रूल आउट करना जरूरी है, और ये क्योंकि कुछ सिम्टम्स ओवरलैप कर सकते हैं ADHD में, लेकिन कुछ जो सिम्टम है ये दोनों साथ भी हो सकते हैं, जैसे लर्निंग डिसऑर्डर, कंडक्ट डिसऑर्डर, ये दोनों, और सब्सटेंस अब्यूज, ये चीज़ें साथ में मिलके हो सकती हैं। ये जरूरी नहीं है कि ये भी हो या ये भी हो, दोनों मिलके भी हो सकते हैं।
And Doctor, how do we diagnose these? Can you tell us?
देखिए डायग्नोसिस का जैसे सबसे पहले जैसे बताया कि जो सिम्टम्स हैं, जो 3 क्लस्टर हैं, हाइपर एक्टिविटी, इम्पल्सिविटी और पुअर अटेंशन, इसके सिम्टम्स होने चाहिए। और ये सिंड्रोम डायग्नोसिस, अगर एक सिम्टम हो तो उसके बेस पे डायग्नोसिस नहीं बना सकते, कम से कम 6 सिम्टम्स होने चाहिए। और ये ज़रूरी है कि ये सिम्टम्स मतलब 7 साल की उम्र से पहले आने चाहिए। ये सिम्टम्स जो है, ऐसा ना हो कि एकदम ही सडनली पहली बार ये 15 साल की उम्र में आ गए हों। और ये जो सिम्टम्स हैं एक सिचुएशन से ज़्यादा जगह पे होने चाहिए। ऐसा ना हो कि सिर्फ घर में ही ये सिम्टम है, स्कूल में नहीं है, सिर्फ स्कूल में है, घर में नहीं है। तो एटलीस्ट मिनिमम 2 जगह में होना चाहिए ये सिम्टम्स जो हैं। और जैसे मैंने पहले कहा कि देयर शुड बी सिग्निफिकेंट सोशल, एकेडमिक एंड ऑक्यूपेशनल और वोकेशनल फंक्शनिंग। ये इसमें डिस्फंक्शन होना बहुत जरूरी है। और एंड दीज हैज टू बी एक्सक्लूडेड from pervasive developmental disorder, schizophrenia, other psychotic disorder, and they are not better accounted for by any other mental disorder like mood disorder, anxiety disorder, dissociative disorder, personality disorder. So ये सब में ये सब चीज़ें एक्सक्लूड करके तब इसका डायग्नोसिस बन सकता है। और it's very simple to make a diagnosis, not that difficult, because there are not many investigations are required. Only clinical observation by parents, by teachers, and in a structured environment. And there has to be a group of symptoms in these realm, that is hyperactivity, poor attention, impulsivity. Simply based on that we can make a diagnosis. And also we can take a history from the parents, and we can take a history of medical history, treatment history, examination, developmental history, family history we can take in the evaluation part, and other relevant investigation, cognitive profile, उसका IQ और वो सब कैसा है। यूजुअली ADHD में IQ नहीं खराब होता है, IQ is intact, educational assessment and degree of impairment what they have. So based on all this is the comprehensive profile of the children who have ADHD, and based on this we can make a diagnosis of ADHD.
थैंक यू डॉक्टर। डॉक्टर मंजू मेहता, आप हमें ये बताएं कि ये जो ADHD का जो मैनेजमेंट हम करते हैं, किस तरह से इसका मैनेजमेंट किया जा सकता है बच्चों में?
The management will depend upon various factors. One of them is the situations in which it is occurring. If supposing it is occurring only in the school, or it is occurring only at the home, and we know that it is because of certain people and certain environmental situations, then in that case we do behavioral therapy, and we give counseling to the family members, and we give specific tasks to the child. In case it is everywhere and it is so severe that the child is not able to concentrate and do the task in spite of having good intelligence, then in that case we generally give them pharmacotherapy, and there are very good drugs are available, and with that the child really improves and he is able to do much better things. It is also school based programs also, because if the child has got problem only with the academic task, then the teachers are given some tips, like for example the child should sit in the front, because if he is sitting near the window or he is sitting at the back, his concentration will go away. If he sits in the front in presence of teacher, has eye to eye contact with the teacher, he can look at the blackboard more easily, then chances of his concentration are better. Second thing is that the task that is given to him should be of his level, that he can do it very well. Many times very intelligent children, very gifted children, they are in a class and they finish the work very soon and they get bored, and after that they start troubling other children. In those cases teachers are asked to give extra responsibility and extra work to these children and give it more challenging sort of a task, so that the child enjoys doing it and he gets absorbed in the task. For other people it may be that you have to break up the task into small steps, and when they are small steps the child is asked to do that, and when he is able to do that he is rewarded for that, and then second step of the task is given. Sometimes in the evening, in the other activities, lots of activities can be given to the child, like for example taking the beads and threading them, or the parents can give them rice and pulses mixed together, where the child has to sort them out separately. Or the child may be given a newspaper and he may be asked to delete a certain alphabet. So these are activities which help in developing the concentration. So It would be basically a management would mean that if it is too severe, the drugs are to be given and certain training is to be given. If it is specific to certain situations, then it's more of training and family therapy, family counseling which is to be given, and that will help the child. Its reward and punishment is also associated with that. And also we have developed a program which is psychoeducational program, in which information about ADHD is given to the parents so that they know what to expect from the child. Over expectation again disturbs and it makes the child more inattentive. In that also, what are the tips how parents should manage, how they should give reinforcement to the child, all those tips are included in that program.
थैंक यू डॉक्टर साहब। एक आम आदमी की भाषा में जब हम बात करते हैं, हमने अभी बात की ADHD क्या है, और तो अगर मैं आपसे कहूँ कि इसको एक आम आदमी की भाषा में एक सारांश के रूप में आप बताएं कि व्हाट इज़ ADHD?
ADHD, if we speak to summarize, it's a child who has a problem of not being able to sit in one place, not able to concentrate, and not able to control his impulses.
थैंक यू डॉक्टर साहब। अब हम जानते हैं डॉक्टर साहब से कि SLD क्या है। SLD के बारे में हमें थोड़ा ब्रीफ में बताएं।
See, specific learning disability or SLD is actually a condition in which the child has average intelligence, yet because of certain deficits in his brain functioning or his processes of doing his academic task, he is not able to do well in the school. For example, he is intelligent, yes, he is not able to read. He is intelligent, yet he is not able to write properly. He makes lots of spelling mistakes. He can do all other things, but he can't count and he can't do maths. So this is a particular condition which we refer to as specific learning disability.
And how can we differentiate between a child with mental retardation and a child with specific learning disability?
The first most important thing is level of intelligence. A mentally retarded child would have an IQ below 70, and when we see at his IQ scores, in IQ when we are doing in one test we have got various subscales: information, comprehension, vocabulary, arithmetic. So a mentally retarded child would consistently get low scores on all the subtests. Whereas when we give this test to a child with SLD, we will find a variability. For example, he may have very high scores on information and comprehension, but he may get a very low score on arithmetic. So there is a variability in the subscales or subscores that he gets on the intelligence test. He has average intelligence, he has average social maturity, he is able to adapt to his environment, he is able to do all the things like any other normal child, but only in a specific area where he has a deficiency, he would be performing poorly. Whereas in mental retardation, it is like a global thing, generalized thing, that in all the areas he is not functioning properly.
डॉक्टर साहब, SLD के कितने टाइप्स हैं?
SLD, again we try to divide it into three broad categories. One of them we call it, which is related to the scholastic problems, in which we have problems like reading, problems like spellings, writing, and arithmetic. Then there are also problems which are related to his social context. As Dr. Sagar was saying, that lots of ADHD children also have problem of SLD. So it could be problem related to his attention, it could be problems where he is not able to express himself verbally, he is not able to comprehend the thing, and he is not able to have an impulse control, which is a thing. And most importantly, they are not able to organize the material which is given to them. And sometimes these children may also have poor motor coordination, like when they are given shoelaces, they are not able to tie the shoelaces even if they are 10 years old. When they are wearing certain clothes in which they have to tie a knot, they may have difficulty in that. So motor coordination, they may be very clumsy, breaking things, dropping things, not able to keep it in a particular place. So these three types of SLDs are generally seen.
Okay. And how do we assess the children with SLD?
We have a battery on which it is not only the IQ but also various these problems are assessed. There are specific questions. First of all, there is a general observation from the teachers and from the parents on the task that the child is doing. Then we also review his academic records. We try to see that how he is doing, his class book, his notebooks, they show that how many spelling mistakes are there, what type of writing is there. He may be starting from one end and going to the down of the page. There could be various problems in that. So there are also lots of indications which the parents would say that he is very slow, he is not able to read at one place, or when he is reading he is skipping words onto that. So that general observation is there. Then the assessment on a standardized battery is there. So with all this information that we get, we can make the diagnosis and we can assess that the child has got specific disability.
Doctor, how can we manage such a child in classroom?
See, this is a disability in which drugs do not have much role. The drugs will have a role only if there are associated problems. For example, if we find that his ADHD is very much there and it is disturbing with his studies, so we may ask Dr. Sagar to prescribe the child with the medicines to control his attention concentration span, poor attention. But rest of the things are that the child has to be given a training. So there is a particular training for each deficit area, and in that we have to do that in a very sustained way, and there are various strategies which are used for the management of this. I would like to explain that if a person has got a paralysis, to bring back the function or the ability or the strength in that particular part, you have to do certain exercises, and that has to be very consistent, they has to be systematic, and they have to done repeatedly, then the person is able to function well. Similarly with these children also, there are certain exercises, mental exercises, which the child has to do, and with that he would be able to function in a much better way. Now, can I give you some examples for this?
Yes, yes.
See, for example, if the child, he is first of all not able to express himself, or when that in the classroom, this is a very common thing, the mother says he knows everything but then he is not able to write anything. So in that case, the child may be asked that one is that he will have to practice with the written expression, and then he will have to practice with the verbal expression. To improve his verbal expression, he may be asked that he reads something from the newspaper and he discusses that with the family members. If we ask them to always study and improve the skill, they will get bored and they will not like to do it. So we also want that his skill and training has to be scattered throughout the day in various activities. So he can tell stories, he can tell the main reports. When he watches any TV serial, he may tell the story to the mother or father or brother or sister in a small words. Whatever experiences he has got, he has gone out, he comes and explains that. So when he tries to first in one sentence, then in two sentences, so gradually he may express himself. Similarly, for the written expression, he may be asked to keep a diary. In that diary, he may write about just 2-3 things, what are the things he enjoyed during the day. First, he may not be able to write, but with little practice and giving him tips, he may actually try, and that can be reinforced and that practice can be made better. Then he also can be given certain cues on which he can write, or certain dash method can be used in which he writes one word and then one word is left at this thing. Second example is, which is a very common thing, that is about related to the spellings. In spelling, this is very frustrating for the teachers and for the parents to see that the child, in spite of learning so much, is not able to write properly. So in spellings, what we do is that one of the methods is that we can teach the child only one word at a time. Then it's important that sometimes jigsaw puzzles are given to them, and out of those, or Scrabble is taken, and the child learns to practice through that. Another method is dash method, in which there will be one blank will be there and the child has to fill in the blanks and he completes the word with that. Another very important and very useful method is that a bigger word is broken into small parts and the child learns that this word has got 3 or 4 parts and he tries to remember those parts and tries to complete that. It is also very important is that he is to be rewarded, he is to be encouraged to do this thing, and also sometimes we have certain pyramid sort of thing in which through pyramids he would learn how to do that. Also lots of newspapers, they give these days some games in which you have, there are certain words are there and you have to make words out of that. So that is another way of building up his spellings and it's very useful method of improving on the spellings.
Okay. Thank you, Dr. Saab. Can you tell us, does the child have any other can have any other problems along with SLD?
Yes.
Is there a possibility?
See,
What
as
type
we,
of problems are?
most of the time what happens is that first initially when his problem is not diagnosed, so teachers think that he is not doing well, so he may be rebuked in the class, he may be punished in the class, the parents may always be very nagging to him that he doesn't study, he is only interested in watching TV and things, so that can cause to poor self-esteem and inferiority complex and the child may actually be not able to develop the way he should do. Sometimes because he is not interested in studies, he may start stealing or showing aggressiveness and fighting with other people. So conduct disorders and aggressiveness can come. Older children, when they know that education is the main important thing and these are the people feel that they are not able to do well. So sometimes depression can also set in with that. But generally when the feedback is given to them and they know that what exactly this problem is and they are encouraged to overcome this, then in a very normal way these children can develop, learn and they can develop lots of good vocations because every parent, their concern is that whatever the problem may be, what vocation or career the child would be able to take up. So learning disability or ADHD is not disheartening because parents can expect a normal life out of these children and normal vocation and career for these children.
Dr. Saab, as you were telling us that these children are intelligent but there are some problems. So are there any provision in examination or government has provided anything for the benefiting or for facilitating these children?
Yeah, with specific learning disabilities, CBSE has a rule and in this if it is certified from a government hospital that the child has severe specific learning disability, then they can give him exemption in a particular, if it is related to reading and writing, it can be there. Also sometimes a scribe is provided, sometimes extra time is given by the CBSE, so it needs a certificate and then the government can do. And recently in colleges also they have made a quota in which certain percentage of children can be admitted into colleges if they have specific learning disability.
And, thank you Dr. Saab. Dr. Sagar, can you tell us ADHD और SLD वाले जो बच्चे हैं जिनको ये प्रॉब्लम्स हैं उनके लिए किस तरह के प्रोफेशंस या वोकेशंस जो हैं वो अच्छे रहते हैं, मतलब किस तरह के वोकेशंस को हम प्रीफर करते हैं?
देखिए ऐसा है कि जो ADHD है और ADHD and SLD can coexist together and basically those who have poor attention, they also have a learning disability and and at times they are interrelated also because the person who is given a task and is not able to do it because of poor attention is obviously will make a lot of mistake, careless mistake because of poor attention. So they may exist together. Now as far as the vocation is concerned, first we should imagine that as what Dr. Mehta was saying, that we should not be completely disheartened. The parents should not be disheartened if a child has this ADHD or SLD problem. Most important thing is that they should come for help. They should take the proper treatment from a proper from the proper center or place, so that at least if they have to recognize from self that this is not something which they can ignore or dismiss, and We should understand that they are in the prime phase, and lot of education is affected, lot of academic career is affected when one is not given a proper treatment. So we should not be disheartened if one has a problem. This is a treatable condition. Let me tell you, ADHD is a almost treatable condition. If there are drugs are available, there are very good drugs available, and there is a proper psychological treatment. There are different techniques are there, behavioral modification is there. So most of the children who have this problem, over a period of time, the problem is resolved. But there are small percentage can at least in 1/3 of these children who have ADHD problem can linger on to adult life also. So what they have basically in children, they have the outward restlessness. Now it is turned to inner restlessness. So if they are, and it is generally seen that they may have inner restlessness, they have poor driving habits, they may have a substance abuse, they may have problems in the workplace, they may have a marital discord, they may have interpersonal problems, and so on, because inner restlessness is causing all the problem at times. And so they should go into a job where not much where sitting is there, because restlessness is something where you have to go out, meet people. They can enjoy much better, the job which they have to go out, meet people, where they are not confined at one place. Like, say for example, I can just imagine a person who has ADHD is not suitable for, let's say, call center job, because there you have to sit at one place whole night, or so they may not, because inner restlessness will be there, and they will not be able to complete the task in time. So any job where they are not confined at one place, where they have so is not a suitable. But most of these people who have ADHD can lead a normal life. They can take any job, but they can just take care where when this problem is severe, where at least they should, because also we should remember one thing, that those who have ADHD, they are high propensity, or they are vulnerable for substance abuse also. They are the people who goes into alcoholism, they go into cigarette smoking and the type of substances. They should avoid these kind of behavior. So at least they are not into this kind of. They should have a peer. They should not have a peer where these activities are there. So these care, if they can be taken, so I think they can lead a completely normal life, and they can be into job, any job what they want, except when they can take care of these aspects about the inner restlessness.
थैंक यू डॉक्टर सागर। आज की चर्चा में हमने जाना कि किस तरह बच्चों पर मेंटल इलनेस का असर पड़ता है, और ADHD और SLD क्या है, और किस तरह इनका मैनेजमेंट कर सकते हैं। यदि आपको इस विषय में और जानकारी चाहिए तो आप डॉक्टर राजेश सागर या डॉक्टर मंजू मेहता से एम्स में डिपार्टमेंट ऑफ साइकेट्री दिल्ली में संपर्क कर सकते हैं, या RCI को लिख सकते हैं। हमारी अगली टेलीकॉन्फ्रेंस इंक्लूसिव एजुकेशन के ऊपर फोकस होगी। इस टेलीकॉन्फ्रेंस में चर्चा करने के लिए हमारे साथ इंटरनेशनल ह्यूमन रिसोर्स डेवलपमेंट सेंटर कोयम्बटूर के विशेषज्ञ मौजूद रहेंगे। समय वही 11 से 12 बजे तक रहेगा। अंत में मैं आज के अपने विशेषज्ञों और अपने दर्शकों का धन्यवाद करती हूं, जिनके सक्रिय सहयोग के कारण यह कार्यक्रम सफल रह सका। मैं EMPC और RCI के अपने सहयोगियों को भी धन्यवाद करती हूं। धन्यवाद।